All right, our next paper entitled Issues with Healthcare Decision Making, presented to us by Dr. Jack Yu and Dr. Mustafa Arch. I'll introduce Dr. Jack Yu first. Dr. Jack Yu is a graduate of Stanford and Boston University School of Medicine. He did his residency in family medicine at UCLA and medical education fellowship and MS in education at USC. He has been on the Adventist Health Glendale Family Medicine residency faculty for over 30 years and is on the Hospital Ethics Committee for 30 years and chair for the last 15 years. He's also certified in geriatrics, hospice, and palliative medicine. Dr. Mustafa Arch went to undergrad at UCSD, where he majored in biochemistry. He completed medical school at Midwestern University in Arizona and is finishing his residency in family medicine at Adventist Health Glendale. He will be doing a sports fellowship next year in Temecula. Welcome to the Tillview. Thanks. Dr. Mustafa.
Our presentations on our healthcare decision making team. Okay, so the team centers around the unrepresented patients, which we define as a person who lacks capacity to make their own decisions, and they don't have a next of kin or family or a conservator. They don't have written wishes, a pulse, durable power of attorney for healthcare, or someone willing to make a decision for them. Minors kind of fit into this as well. We'll talk about in a couple of slides. So these patients' hospital courses involve barriers and hurdles that we face, who will make their medical decisions when they don't have capacity, what is best for the patient, and what decision would the patient make. We kind of emphasize substituted judgment a lot in this team.
So some of these slides are borrowed from my friend and colleague, Susan Pietro. So, I went the wrong way. Okay, so this is a graphic way of looking at the hierarchy. So adult patients with capacity, 18 or older, and they can't do it. The surrogate decision maker does it. If they can't do it, an agent, usually advanced directive healthcare. And if they don't have it, perhaps there might be a conservator. If they don't have it, then the closest available relative. And then finally comes down to us, our multidisciplinary committee, which is a subset of our ethics and risk management. So the question is, who can make a decision? Who is an adult? In California, which is where we are now, it may be different in other states. Adult is anyone who's 18 years or older who has a legal right to make all healthcare decisions for him or her of themselves or their selves. Sorry, I haven't got that gender thing down yet. And that includes consenting to medical treatment, refusing medical treatment, or may include life-sustaining treatment. For minors, the short version is if they're married, they're military, they're emancipated, they're self-sufficient, has to do with pregnancy, abortion, rape, and then a number of other little exceptions. And this is the chart that you can look at later on. There are quite a few different things, most of the ones I mentioned. And then we're not going to really address this, but there are also some other exceptions that are for autopsy, for organ donation, and disposition of the remains. We're not going to really talk about that so much because that's not what we do very often. So what is capacity? And we're not talking about competency, which is what the courts decide. Patients presumed to have capacity unless they're determined to lack capacity. In California, that's based on ability to understand the nature and the consequences of a decision and the ability to make and communicate a decision. So they may not be oriented, but they understand what the decision is about and what the consequences are. They still may have some capacity or limited capacity, or at least be able to influence us by giving a preference. The primary care physician may determine capacity. It may also be a consultant like a neurologist, a psychiatrist, a mental health professional. So what is the solution? What we do at our hospital, and this is our experience. We've been doing it for about 10 years now. It's a healthcare decision team consult, basically. So when that happens, someone will usually call me for ethics consult. I'll say, no, you don't need an ethics consult. You need an HDT meeting. So call risk management. They're called, and then they coordinate the team, which involves me and other members of our ethics committee. First, or second of all, due diligence done by social workers. They basically look everywhere. Does this person have a relative? They go online, they call the contacts, they call the police, they call everywhere. And it truly has no one, they don't have capacity. Then the team meets. They take into consideration all information available and appropriate to the patient's medical condition, including information that may be available from family or friends regarding the patient's preference. Sometimes the family or friends don't want to make any decisions. They don't want to be involved, but they may be able to give us a preference. So we take into consideration their personal history, values that we can find, and then based on sound medical advice and without the influence of material conflicts of interest, which we'll talk about a little bit more. So we can go next. So we review the diagnosis, prognosis of the patient, and make sure it's accurate. And then we determine the appropriate goals by weighing the following considerations. And this is from our policy. The patient's previously expressed wishes, if we can find them, the relief of suffering and pain, preservation of improvement or function, recovering of cognitive function, quality and extent of life sustained, degree of intrusiveness, procedures, risk or discomfort treatment, and then cultural religious beliefs to the extent that we know. So the structure team is myself, usually, or my representative, risk management, social worker, the patient's nurse, the physician who requested it, which may be the PCP or the consultant. Sometimes it's a hospice, a community member, and we have a couple of them. One of them is a JDRN, which is very helpful. And we have a chaplain. We are in theory available 24/7, but it's hard to get the team together that quickly. Sometimes it can be Zoom, but they're done as needed. And the decision must be unanimous. So some examples of the cases we've been asked to decide on, like our PEG and trach, for example. Usually a patient who's obtunded a fractured hip, for example. And there's often discussion about that from the orthopedic surgeon who says, this is an emergency, or is it an urgency? And finally, we come down to it's an urgency. Yes, we do understand that the sooner you get it done, the less complications there will be, but it's still more of an urgency than emergency. And I define that later. So what is emergent? So they're required for alleviation of severe pain, or if not done, will lead to serious disability or death. So yes, a hip could be a little gray, but usually that we still define that as a urgency. Emergencies, appendectomy for a ruptured appendix, for example, aortic dissection, cardiac stent for ACS, thrombolysis for a stroke, all very time dependent. So some of the issues we come up with, conflict of interest. So on the committee, I am the ethics chair, so I'm part of the MEC, the medical exec committee. Almost everyone else is an employee of the hospital. So you could say there's some conflict of interest there because basically the hospital wants to decrease length of stay and not have the patient be there unnecessarily. Sometimes the sources of information have conflicts of interest. For example, the people who are giving us the information may be a family member or someone who takes care of the patient, and clearly they want the patient to remain alive. Sometimes there's bias. We try not to be biased, but clearly we all have bias, whether we know it or not. There was a study, I couldn't find it later on, but showed that younger people and older people have a different opinion about what quality of life is acceptable to them. So the age of the people on the committee may make a difference. Disability, we try not to be biased about this, but sometimes we feel like, wow, this person has, his underlying mental status was very low. He was nonverbal. Should that make a difference? Socioeconomic, Michael talked about this earlier. Sometimes we say, oh, if they're homeless. We try not to be biased about that, but sometimes we are. And then some of the other issue is who makes up the HDT. If we can't get everybody involved, it's just the three of us. It's myself, social worker, and a risk management person. The other thing is who should be making this decision? We who maybe known the patient for the length of their hospitalization, or maybe someone from the nursing home where they've been living for the last 3 years, or the board and care where they've been for a few years. Who determines capacity? So that's usually not a big issue. Oftentimes there's psychiatrists who's done it, or psychologists, a neurologist, or primary care, or physician. And then the advanced directives. The advanced directives can guide us. Sometimes we can't necessarily follow them because they haven't been executed correctly. They haven't been signed, maybe they haven't been dated. Sometimes they're just really old. So would they want the same thing they said they wanted 2 years ago when they were verbal and walking around, and now they're nonverbal and in bed, and they've been like that for the last 3 months? That's almost the last one. Yeah. So the decision is made by a vote of the team, and it has to be unanimous. If it's not unanimous, then we just continue on what we're doing. And then what happens usually is it becomes an emergency, or something happens and the HD team makes it unanimous. So that means sometimes we have to meet several times. But in all things we do, we try to err on the side of life. So for these patients who are disabled and oftentimes alone, whether by choice or just the way it is, they are certainly vulnerable. So we try to help them and make decisions that they would make. All right. Any questions?
Thank you so much. We have a couple of minutes for questions. Please feel free to raise your hand and I'll run the mic to you.
So does it mean you can make a decision for non-emergent cases? I'm from Washington State, and we have to have a legal guardian order established. And so we have patients sitting in the hospital for 6 weeks or so before we get a guardian if it's not an emergency. So I'm impressed that you can do it.
This may be state because it's California and we have California rules. Maybe someone from Washington knows about this. Dr. DeLeon, do you know about this?
No, I don't. Sorry.
Okay.
I'm not aware of the differences.
But I'm on the team. I know the cases. We have to wait then until we have a legal guardian who can decide if it's a non-life threatening. If it's a life-threatening situation, we can go ahead. If it's a non-life threatening, we have to sit there and wait for the peg until somebody says you can do it.
Health.
The state then appoint a guardian?
Very quickly.
No,
Oh, that's the problem.
that's a problem.
Takes a while.
That is the problem.
Right.
And in the meantime, you cannot do any change in the status quo.
That's correct.
You have to continue whatever treatment is
Yeah.
being administered.
That's
Yeah.
That is correct.
One question I would have is, we have a similar process. Oh, sorry. Thanks. We have a similar process and some of the more difficult cases involve withdrawal of life-sustaining treatment. What is your experience in withdrawal of life-sustaining treatment for unrepresented patients?
Okay, so it's still the same ethics consult type of thing, benefit, risk. Oftentimes I'll ask, are they hospice candidates? If they're hospice candidates, there's no point. If they have terminal cancer, there's no point. And most of the team agrees with that. I think the more difficult area is when they're, let's say, vegetative, and they've been so persistently for 3 months or more. Then oftentimes we have, I won't say disagreement, but it's not unanimous. But we tend to err, at least I tend to err on the side of life. And then we discuss it, and most people come one way or the other eventually.
Dr. Yu and Dr. Arch, I was wondering, would your team ever be called into action if a distant relative, someone who is further down the list of appropriate surrogates, wanted to be involved but had minimal, call it moral authority or standing, distant or alienated or not really in possession of much additional knowledge about the patient, but possessed of a strong opinion, right? I mean, isn't there a little bit of a conflict about, it's almost as if your HDT team might be in a good position to weigh in, but someone else might have a differing opinion who's got a distant connection to the patient?
Yeah, so that is actually part of the due diligence. The hopefully would find that person and say, would you like to be the decision maker? Oftentimes they'll say no. And if they say yes, then someone else might call me and say, I need an ethics consult because I think this person is not making the right decision. Or is not making decisions in the patient's best interests. So yes, that does happen, not very often, thank God. Because that's kind of our nightmare, right? That person will then threaten to sue everybody and so forth. And I talk to risk management as well.
Thank you so much for the presentation.